very pleased today to have two people from the All Nations Health Partners. They'll go into the history and they'll talk about it, but it's very important to Kenora where they had started and where they are. So I think it's really important that we all know and support what is going on in our community. So today we have Colleen Neal. She's the outgoing lead, handing the torch to Lisa Doerksen to lead the All Nations Health Partners Ontario Health Team, and resuming her role as the Executive Director of the Sunset Country Family Health Team in Kenora. Colleen's dedication to the roles reflect her unwavering commitment to creating a healthier and more connected community. Colleen brings her willingness to foster communities or connections between healthcare and service providers and communities that they serve. Through her leadership, she encourages innovation and ensures the service providers play a vital role in delivering responsive care to individuals across All Nations Health Partner geographic region. Prior to her role in healthcare, Colleen spent 15 years managing recreation and community service. I'm pleased that I worked with her with the Kenora Association for Community Living before she moved on to the city, and I think her community connections speak to where she is today and how she can bring service provider and healthcare together in the role she has. And then with her, we have Lisa Doerksen. Lisa is a registered social worker by training. Lisa has spent her career serving different leadership roles in the field of child and youth mental health and school mental health at a local, regional, and provincial level. Lisa has experience in project management, knowledge and system collaboration and planning and implementation of health transformation initiatives. Lisa is a lifelong resident of Kenora and in her spare time enjoys fishing and spending time with family on the Lake of the Woods. Again, Lisa, I spent a lot of time in her role when she was in children's, and a lot of that, again, that community-based development and connection, and I think the two of them are going to be dynamic for us today. I'd like to all, if you could help me in welcoming our speakers.
Thanks, Sheila. So just to clarify, we may have disappointed a few today. Let's start it with that. Isn't that a great start? We are here to talk about the All Nations Health Partners, the Ontario Health Team. We are not going to be talking about the All Nations Health Partners Hospital. That is a separate project. The hospital is one of our very dedicated and one of our leading partners in the work of the Ontario Health Team. However, the project is a separate project from that. It's not something that we do. And I really do hope that you invite Ray and Cheryl to talk about the hospital. I think it's it can take up a whole session itself, and it's a very exciting project that is already moving along well, and where we are all as a community going to be needed to lean into that project to bring it to fruition. So again, I would invite you to have them come and speak to you on that. But today we're going to stick to the partnerships of this group. So what is an Ontario Health Team? Just to understand that. So back in 2015-ish, there was a group of doctors, one of which was Jim Retzen's daughter, did a deputation to City Council, talking about the cross-border issues that we all have in our healthcare, and even at that time, the depleting number of physicians that we had in our community, and the deficits that we had. It's continued to erode. However, in 2019, there was, from that call, a group of healthcare providers got together and we decided, how are we going to fix this and what are we going to do? Alongside of that, the province was very aware that we have way too many silos in our healthcare system, that providers and funding was often in competition and we weren't working together. So there was a call out that went out to different groups across the province to become an Ontario Health Team. At that time, there was a mass that you had to meet of a population of 50,000 or more. 50,000 is the statistical significant sort of tipping point of where you can start to make change or really track change. We don't need that. But we did do an appeal, and lo and behold, the All Nations Health Partners became one of the very first Ontario Health Teams in the province. That was tasked with looking at a defined patient population, was looking at the scope of services that we need to work together in, to really have a patient, partner, and community engagement, not just those that are paid, but those with lived experiences, and those with patients having a strong voice, not just in engagement, but at the table for co-design. Really starting to look at what the province calls PREMS and PROMs, which is the patient experience and patient outcomes, and measuring those things that are important to patients, not providers. How are we going to leverage digital health? The leadership and accountability and governance of those groups, and right now we'll talk about that, of who's involved in this partnership. But we have 15 partners, and how we work on an accountable governance for all of us. And then again, not competing for funding and incentive structures, and again, really looking at how we're measuring our outcomes. So that's what an OHT is tasked at doing. With that, the province then looks at what they called a quadruple aim. When we started in this work, it was really looking at is this quadruple? This is quintuple. It was looking at a quadruple aim. There was 4 things. With the work again, and the work that we do in Truth and Reconciliation for Health, we said it needs to be quintuple. We kept going back to the province and saying, if we're going to succeed as the smallest OHT, and not only the smallest, but the only OHT that has true Indigenous partners at the table, we need to look at equity. If you're not going to put equity into your aims, we're going to continue to struggle. So it's nice to see that the province has finally looked at equity in healthcare. And again, as you know, that means also those with a provider and without a provider. We have the haves and the have-nots. We must have that, or we're not going to continue to get anywhere. Okay? So this is our story. Again, we started in 2015. We became the All Nations Health Partners. We became an Ontario Health Team. And just recently, even though we still managed to come up as the smallest and are always raising our hands to say we need a different way of doing this, the province chose only 12 OHTs out of 57 across the province to accelerate to maturity, to be designated under the Connected Care Act, and really show innovative ways of doing healthcare. And the All Nations Health Partners, because of the good work we've done in a short period of time, was chosen one of those 12 OHTs. So I know sometimes you don't hear about us. I know sometimes we don't brag in the way we should to show all the good work that is actually happening, because it's always very easy to see all the good work that still needs to get done. But I can tell you there's lots of foundational work going on in the background, so that as we move forward, we're moving forward together. So that's where we are today. Our geographic area is from Wabsama down to Whitefish Bay into Nestor Falls. So although we didn't have the 50,000 population set, we probably have one of the larger geographic areas. So some of the OHTs are like Toronto East, Toronto West. We're Kenora region, but we've got a massive geographic area. And these are our partners. And I'm going to pass this off to Lisa.
All right, and if it's okay with everyone, I am just going to sit, as long as you can hear me okay and see me okay. Thank you so much, Colleen, for starting us off, and thank you for the land acknowledgement. And at the beginning, I just feel that it's really in the true spirit of collaboration and what is already in place through the good work of the All Nations Health Partners in terms of non-Indigenous and Indigenous-led initiatives that are happening here locally. So it's in that good spirit that I share. These are our 14 partners. Some of you may recognize organizations that you in fact have worked for on behalf in your previous roles. So we certainly have the Kenora Chiefs Advisory, Sunset Family Health Team, the Lake of the Woods District Hospital, the Canadian Mental Health Association, Kenora, Firefly, Kenora District Services Board, KACL, WinHack, the Northwestern Health Unit, the Township of Sioux Narrows and Nestor Falls, the City of Kenora, the District of Kenora Unincorporated Area Ratepayers Association. It's quite a mouthful, but they're a very active partner. We also have the Métis Nation of Ontario. And finally, we also enjoy having the participation of Grand Council Treaty 3 in an observing role. So not signatory to the All Nations Health Partners, but certainly walking alongside our work in terms of the different working groups and activities that are taking place. You see okay? Okay. The All Nations Health Partners, Ontario Health Team, utilize a collaborative decision-making framework, which really sets out the purpose, function, and processes for our work. It is a living document, and it's going to evolve over time. At any time, a team member from any of the membership organizations may propose changes to the framework for discussion at one of our All Nations Health Partner table meetings. Changes will only become effective when there is general agreement and good discussion amongst the partners. So this was the framework that existed prior to our designation, or our evolving designation as an Ontario Health Team, but it's proven to be a really effective mechanism to really weigh key considerations as it relates to whole of Kenora and whole of community in terms of healthcare. Supporting the work of those who participate in the table are many very active working groups. So we have a number of active working groups who really are focused on developing an integrated, person-focused vision for healthcare in Kenora. And they really are deeply engaged in the development and implementation of this collective vision. So what we ideally want is to see less silo in the system and better continuity of care for all Kenora residents in terms of those good pathways and positive care experiences. This is just some of our active working groups, so we certainly know communication is key. You can appreciate that given our geography, given the organizations that are at the table and their various mandates, communication can be both an opportunity but a tremendous challenge. So the All Nations Health Partners certainly recognizes that communication can really be a driver, both amongst our organizations, but also to those of us living and accessing the healthcare system here in Kenora. We know that data and quality improvement is really important. Digital health, Colleen mentioned earlier, is the way of the future, and how do we optimize and streamline ways in which to really leverage digital health in a way that gets us access to needed services. Of course, we need to have good governance structures in place, and there is a lot of activity taking place in modernizing home and community care. Our mental health and addictions working group has been very active over the last few years, and Colleen mentioned earlier that the impetus for really a lot of the work in coming together was around recruitment and retention of physicians here in our area. We have two wonderful co-chairs for our primary care advisory group, and we also have a larger working group that's supporting a lot of things that are happening in primary care. And then, of course, whenever you work in healthcare, you need to pay good attention to and be very vigilant around privacy, security, consent, and all of those good things. In addition to the working groups, we also know that health transformation and system change places a really important and needed emphasis on engagement and planning alongside key stakeholders. For the All Nations Health Partners, we have several very active advisory councils, including the Clinical Primary Care Advisory, which is co-chaired by Dr. Jilly Retson and Dr. Shannon Weeb, our Traditional Healers Advisory, which is led and overseen by Elder Eleanor Skeed, and Rita Boutet, who is our chair of the Patient, Family, Elder, and Caregiver Advisory Council. And these groups are really quite active and at the table alongside of all the work taking place, which means really good things in terms of keeping us grounded in the realities of accessing and receiving care in our area. Colleen did mention that this is fairly new, so as of September 27th, 2003, the Ministry of Health did announce that 12 of the 57 would be accelerated, so we are very deep into work in this accelerated phase. And in fact, today marks a due date for one of our deliverables, which is around implementing clinical pathways. So in the days and years ahead, There's going to be a tremendous amount of work in developing integrated clinical pathways. What we've started off with is focusing on 2 areas of chronic disease, including heart failure and COPD. Please tell me the health acronym. COPD.
Chronic obstructive pulmonary disease.
Thank you.
Asthma.
Yes. Yes.
Used to be emphysema as well. So anything upper respiratory pulmonary.
So we actually are doing that action planning here alongside of 4 other Ontario health teams that are located in the northwestern Thunder Bay region, including the All Nations Health Partners, of course, Healing Working Together, which is the group out of Thunder Bay, and also the Healing Waters, which is the Red Lake catchment area, and our colleagues in Rainy River. Yes, so they're at different stages, but we decided that regionally we're better and stronger together, and we certainly recognize that in order to access that specialized care, oftentimes we're needing to travel and needing to access regional support. So this is an effort that's currently underway right now. We hope to learn and we hope to replicate what those good clinical pathways look like in other areas of need in terms of healthcare. Certainly another big emphasis over the next little while as an accelerated OHT is around system navigation, home care readiness, and implementing supports, which Colleen mentioned earlier, for those unattached patients. And finally, improving early detection and intervention for chronic disease. Did you want to add anything about that in terms of the cancer screening stuff, Colleen?
Yeah, so previous to this work, we did have cancer screening pathways that we've been working on locally and making sure that people have access to cancer screening, and those who are unattached can still do cancer screening and have follow-up through our work with Cancer Care Ontario. We've also been working, one of the other chronic diseases that we worked on last year was diabetes, with an emphasis on lower limb preservation with the high number of amputations that we have in our area. One of the things that drives some of these, how we move these projects along, is sometimes they're provincially told. So we're told by the province, we want you working on heart failure, we want you working on diabetes. But right from the very beginning, Ontario health teams were tasked with creating their priorities based on their health information data. So we really are trying to dive into our data, and that's another thing that's very difficult for our area, because our data in Ontario is driven by an insurance system. So our data in Ontario, or a lot of the data pools that the province utilizes, is based on what is billed to OHIP. A lot of us travel to Winnipeg for our care. A lot of us have family members that were even born there. So even the number of births we have is out of whack from what we actually report in Ontario. How we track a lot of our chronic diseases, again, through specialty in Winnipeg. So how we move data through our system right now is really important. When we first got our data set for our OHT, we clearly saw right away that it was not representative of us, that it didn't look like we know as providers how it's working. So this is why it's really important for us as an Ontario health team to really be involved in this work, so that we can utilize some of the provincial dollars and some of the provincial systems that are so important to them, to get them to realize how it really is different here.
Mm-hmm. So, thanks, Colleen. Over to you.
Over to us. We just thought this is kind of one of those fun facts. So you see our logo. We all know how important branding can be. The All Nations Health Partners really wanted to come together under one logo, and really we had a group of elders that helped us with this and really develop, and rather than just have something that was pretty, we wanted it to be pretty too, but to celebrate the colors and the diversity of our story and how we came together. So our brand represents health and wellness experience, but also inclusivity, and again, the vast number of communities that have come together to bring this work together. So, will you flip that for me? When you look at our logo, you'll see that you've got the 4 stylized birds representing the sacred thunderbird, the wings that are outstretched to show that we are trying to improve care and caretake of the people that rely on us. The four birds create a partnership within their wings, joined together, forming a circle. The negative space between their wings and feathers resembles the lungs of a healthy organism and the networks of the veins, nerves, and the bones that we look to in any healthy system, or pathways or avenues that connect all aspects of one being. At the end of each avenue is a dot. That dot is very purposeful. It represents the communities of the All Nations Health Partners and the number of communities that we have in our geographic area. And the textured watermark, if you look closely, that is imposed over the circle in the wings is the turtle and the turtle shell. And the turtle in our watermark has 13 sectors representing the 13 moons that make up a year that we move through into our system. So when you see that, you may not see that right away, so it's important that we share that. And again, it was the elders of our communities that came together to really work hard on coming up with this logo that we're so very proud of. So we tried to keep it brief. There's so much on that goes into all the work, so we're happy to take questions. We know we have a lot of questions. We know we have a lot of disparities in our healthcare. So if you have questions for us, we're happy to help with that.
It's interesting when you see the statistics. We're kind of in a more unique situation here because the specialty care just across the border, the alternative course is Toronto, Hamilton, or Ottawa for that care. Whereas if you're in Toronto, you've got everything right there. When you look at the number of people who have gone to Winnipeg, and I've been there twice for specialty work, how do you incorporate that into your data?
And that's exactly what we're working on. So we're trying to figure out, so right now we've got projects going on for centralized waitlist management to surgical services, but again, it's all very Ontario focused. So we have that additional burden of trying to ensure not only how do we take in the data, but you as a patient, when you get to Winnipeg, they have your imaging. They have your chart. They have those things that you're not carrying those with you like everybody else has to do as well.
Well, sort of.
Yeah.
Because the two systems aren't tied together.
That's what I'm saying. We're working on.
You have to get a separate set.
Yeah. Nobody wants a second colonoscopy, right? Nobody wants a second set of things just because your data or your test results didn't flow that way. So we're working really hard to try and figure those things out. We're working really hard, again, not to use, you heard me on my soapbox about using insurance data as indicators of good health care. Family health teams have nurse practitioners that don't bill. So their data and their services don't go into any mechanism. The physicians that work at WinHack at Wasagizik don't bill because they are employees. So all that work isn't billable work, so that data isn't pulled from insurance data. Insurance data is not a good indicator of quality. It's not even a good indicator of quantity for us. So again, the number of people that go into Winnipeg. So we know we've got massive holes in our data. So when we do population health management and how we attribute where we're going to put our resources to try and impact our health outcomes, we at least need to be able to do a head count. Right? And when so many of our births and specialty births or high-risk pregnancies are in Winnipeg, how do we count those? There's less than 200 births actually in Kenora at the hospital every year. So we know we've got holes in our data. So we are working at that. So some of these things that we're taking into consideration requires physicians sitting at the table saying, yeah, we know we're sending their patients. How do we attach our electronic records so that we can pull data to say this is the number of heart failure, conditions that we send out of the province. But we've never had to do that before because it was one practitioner doing their role for their patient. So working together and collaboratively to ensure that, it's not just you, and it's not just you, and it's not just you. And collaborating, really looking where we need those resources to go is very, very important. And that's why that's the work you don't see, right? You don't see that when you go to the doctor's office. You don't feel that right away. Those are those foundational strategies that we are spending a lot of time and energy on so we can make the system better in the future. Sorry, I'm not sure how you, yeah.
Very interesting presentation. So I'm curious to know, where does the naturopathic path fit into this? And being in Northwestern Ontario and having grown up here, where does the indigenous healing process fit into
You
all
want to go
this?
back a few slides?
Oh, yeah, sure.
So one of the things you may have noticed, we had 3 advisories. And those advisories within our decision-making framework have votes and say at the table. Traditional Healers Advisory has the same weight as our clinical advisory. So just from a respect point of view, the votes or how, we haven't had to vote at our table. We really do work nicely in consensus. We hold our calls to truth and reconciliation through health very strongly. We have our health directors when we move into our primary care working groups. We have our healers with us. We have our traditional advisories with us. We're working on a new compensation model right now for physicians that doesn't rely on rostering and, again, sort of that OHIP model. And in that, we are working with our chiefs are going to have a role in the decision-making of how health human resources then are resourced to those First Nations communities, because access is one of the big equity indicators for sure. So right from the very beginning, it was our chiefs, we came together in ceremony, the All Nations Health Partners came together in ceremony, and then we became an OHT. So those values that we have, our values are the 7 grandfather teachings. We start each meeting with an elder opening our meetings. We are trying to very much embed and respect that way and respect the healing and the pathway. So when we do a pathway, it does include our healers.
And something I would just add to what Colleen is saying that certainly has been clear to me, this is the start of week 4 in the role, is that these discussions and the planning occur within a climate of trust, which I'm well aware has taken place over the course of all the conversations that have occurred prior to being this accelerated OHT and starting in a good way in ceremony in 2017. So I think in many ways we're seeing the fruits of those good conversations and the trust that's been established over time.
We'll take one more question.
It's actually 2 points. Partnerships are so important to all of us, and there's an opportunity for you to give back to your partners. Show your partners the slide where you have the logos of all your partners and ask them to see if they can see their logo. Some of your partners don't show up. I couldn't see who they were.
Okay.
So their branding sucks.
Okay.
And you can
That might have been our fault. Maybe we should have done everyone on each page.
It's not your fault,
Yeah.
but you can do a service
No,
for
it's a
your
good
partner
point.
by showing them, hey,
Make it just
maybe
very
you wanna make
visible.
this thing stand out.
Yeah.
I think one of the things we'd like to do too is ask all of our partners, even on their emails and other places, proud partner of
Yes.
Yeah.
All Nations Health
Yes.
Partners, right? We have work to do. Again, we've been a very small but mighty group. I would say, even myself, I've been doing this now for 3 years as the lead. I've also been running my own ship of my organization. All of us have done everything we've done, even to get us to be chosen to be a 12, in addition to the roles that we play in our organizations. I appreciate your comment. And we'll do
And the
that.
second point is, I'm okay to do another colonoscopy if I don't have to do the diet prep.
Yeah, that was the worst part.
We have one last question just
Yeah, just further to Fred's comment about the partners, I see one missing, and it's a partner, it's the Wigwaz Elder and Senior Care.
Well, under the Kenora Chiefs Advisory,
But we are a separate entity.
I understand that. That would be up to your partner organization to bring that forward, because these are signatories. So just to explain, so when the Ontario Health Team came into being, organizations signed on to an agreement. Unfortunately, Wigwaz wasn't
We weren't in existence.
in existence at that point.
Depending, I don't know.
And there is a maturity model that will come with this too as well. There's lots of people missing. There are lots of organizations that are missing that we either have invited to the working group tables that are on our working group tables with us. That we know. OPP is another one that does a tremendous amount of work with our mental health and addictions group. But you're right, there is a maturity model that needs to come with this that is more inclusive of our community organizations. So thank you. Yeah.
And on that note, and the last slide is just bear with us as we do work on updating our website. It is a fairly good website, but certainly there is information that's missing. And so we're kind of looking at a refresh across a couple of our social media fronts as well as our website. But in the interim, any questions? And of course, if you have interest in particular around the patient, family, caregiver, elder advisory and participation, let me know. My email is up there, and if you don't have it written down, Sheila knows where to find me. So thank you so much for letting us come today.